session that I'm calling New and Improved is going to be really inspiring. I hope it gives you hope. I hope that as you listen to these young clinician researchers about what gets them excited about coming to work every day, whether it's to treat you or to do work in the lab. I hope what gets them excited gives you a sense of hope. Beacon has been around for 18 years. Back when they were started, the newest thing was BCG, and it was 20 years old. And that continued for quite some time. And then about the time that I came to Beacon 8 or 9 years ago, the dam started to break open a little bit. The first immunotherapy was introduced for advanced disease patients. And then came the second, and the third, and the fourth, and the fifth. And then they took one away, and they were back to four. And then they added targeted therapies. And then they added antibody drug conjugates. And now we have gene therapy. So there are so many things that at our scientific meeting, at our think tank that we do every August with researchers and clinicians, we've had sessions on how do you sequence treatments. That was never an issue when we started because there was no sequence. There were no options. It was you either do this or you do that or you get your affairs in order. And so now I'm just so delighted that we have two medical research experts from our local university medical center, Vanderbilt University. I would like to welcome urologist Dr. Amy Luckenbaugh and medical oncologist Dr. Catherine or Katie Beckerman. And I'm going to give them time. I have some questions. They've put together some slides. We're going to do a little back and forth. If you have questions, write them down and we will do the microphones at the end of the session. So I'm really thrilled. I'm going to ask you first to introduce yourselves. Give us a little background. Why are you in bladder cancer, doing bladder cancer work? So Dr. Luckenbaugh, tell us why.
I think, so bladder cancer is by far my favorite thing to take care of the things I take care of. There's so many options for treatment. Truthfully, now there are even more. And I think patients, I get to build a long relationship with patients, whether they like that or not.
Yeah, we heard that before.
We get to get to know each other fairly well. I think that's one of my favorite things about bladder cancer. And truly, it's the patients. I think bladder cancer patients tend to be the most grateful that we take care of, and that's what keeps me going to work.
Dr. Beckerman.
Yeah. Thanks, everyone. My name is Katie Beckerman, and it's truly a pleasure to be here. Looking forward to this session and hearing your questions. I think what got me excited and has me, just myself feel so rewarded is, I think, as Amy just said, the gratefulness is just astounding. And I think to the point that there are just so many new advancing things. There's so many novel drugs, new chances, and I think we're both going to talk today about, just in the last 5 years, how many things are changing, and it's changing so fast. Sometimes it's hard to keep up with. And so I think that's what has me excited right now.
Yeah, I find it fascinating just to watch you all. You're covering the spectrum of disease, the non-muscle invasive in the urology space. And then they kind of share and partner and co-treat for those muscle invasive patients that might need medical oncology and urology. And then, of course, the advanced disease are more in the medical oncology space. But when you're doing this and you're working across the spectrum, I know that there's probably some things that are just like, wow, I love this. This is the coolest thing right now. Tell me from a urologic perspective, what is the most exciting thing, the buzz that's going on right now?
I think the most exciting thing for me is the alternatives to BCG. There's so many of them coming out more and more and more and quickly that are fairly successful for BCG refractory disease, which is huge because it can avoid doing a major surgery take away my job. And so I think that's really exciting. That's what excites me the most right now.
Okay, what gets you going?
Yeah, I think for me it's maybe two things. So one on the clinical side, and I'll talk a little bit more about it, but there was just recent, as in like a week and a half ago, for the first time in I think 30 years, we've improved overall survival, and we'll change the standard of care for patients who have advanced metastatic disease. So I'll talk a little bit more about that. And then I think the other thing I just can't decide which one's more exciting, so I have to mention them both. The other thing is, I think, myself, I'm very passionate about translational research. And so specifically, we're learning a lot in the metastatic setting about ctDNA. It's a blood-based marker. Can we use biology to understand if cancer is still there or if you need a drug to treat it? So I think we don't know the answer, and that's what I'm excited to see where that goes.
Yeah. I mean, did you think about this when you were going to medical school? Before you even got into your specialty, did you think, wow, I'm really excited that I'm going to get to know all of this information about genetics and DNA and all these other things? Did you really ever project that this was going to be important for what you were going to do? Because you were going to be doctors.
No, I did not predict that would be important for what I did. Absolutely not. But it is great that it is becoming important. It's becoming important in non-muscle invasive disease as well. And that's also very exciting. I'll talk a little bit about that as well.
Yeah, and I think for me, so my training, I have a PhD, and this is why I am so passionate about it. Is I want it to be a precision-based treatment. I want it to be an individualized treatment approach, and it should be, as we learn more, based on genetics and genomics and ctDNA and all these different things. So I love that is finally coming into our patients' options.
What I think is really impactful is going forward, we're really looking at the right treatment for the right patient at the right time. So this is a good thing. So our format today is going to be an interactive dialogue. I'm going to ask a question. Either Katie or Amy will kind of respond. And they've put together some nice slides to help kind of keep you going through this so you can see what they're talking about. And we will leave about 30 minutes at the end for Q&A. And we'll do the same thing we've been doing with the microphones and everything else. We are recording this session, so it will be on our website. And, if I have your permission, I can share your slides also when I send out the final email with everybody at the end. So we're going to start again at the beginning of disease with a non-muscle invasive. So Amy, what's the state of science on screening tests for bladder cancer? Because people can go for mammograms to see early on if they have breast cancer. They can get their PSA tested to see if there's a thing they should pay attention to for prostate cancer. Why is it that we don't have a pee in the cup test for bladder cancer?
That is a great question. And so screening, the difference is between screening and surveillance is screening, we're trying to catch something early that you don't have, whereas surveillance are those cystoscopies once you have cancer. And currently screening relies on a primary care doctor to check a urine sample, which is often unpredictable. It relies on you then to subsequently have blood in your urine, whether it's with your eyes that you've seen or under the microscope, microscopic hematuria. And then it requires the primary care doctor to refer to a urologist. And part of the issue is that many people who have blood in their urine microscopically don't end up having bladder cancer. And so a lot of primary care doctors may stop at that step and not refer because they may chalk it up to urinary tract infection, a big prostate, kidney stones. And so there are so many things that can cause this. It's really an imperfect test. But part of the reason it remains imperfect is because bladder cancer isn't as common nationwide and internationally as prostate, lung, colon, and in women as breast. So the things that we screen for are things that are extremely common, like the top 4 and the top 3 things listed for men and the top 1 thing and 3 things listed for women. So prostate cancer, there's many more patients with it, so it's easy to develop a screening test and to prove a benefit. Whereas with bladder cancer, it's hard to develop that because, relatively speaking, the percentage of people who get it, it's very small, and the percentage of people who eventually die from it is even smaller. And so that makes it challenging to develop a screening test. And this just kind of emphasizes that the more common the cancer, the easier it is for the government and insurance companies to justify screening for that cancer. And you know, in some regards, that's a little bit about money. It's also about, are we going to overdo a bunch of tests for people who may not have bladder cancer at all? And so the AUA actually just tried to kind of tailor this a little bit. But what's interesting and I think dreadful to patients is that although they tried to tailor it based on your age, whether you've smoked, how many red blood cells are in the urine, if you fall into intermediate or high risk categories, and according to our guidelines, everybody gets a cystoscopy even with these new guidelines the AUA put out. It's only the low risk patients, which is such a small percent of patients, only 5% of patients that make it to urologists fall in low risk. And so almost everyone's getting a cystoscopy that sees us. And I know that is a point of contention for many people.
It's a fairly invasive procedure, right?
It is.
It's not
it
a
is.
pee in your cup
It is not.
procedure. And even, you know, this is a perfect segue for what's next too, is surveillance. You know?
Yeah. And
this is tough.
And it's hard because this is the best thing we have right now. I don't know that it will be the best thing that we have forever. There are some screening strategies that they're trying to do using biomarkers. This study is being performed at UT Southwestern, and they're looking at patients who are low risk, and they actually go on to, in addition to the standard urine sample, to get a CX bladder test, which is a test where they look at basically the genomics of the urine. And then they decide if that's positive, those people get a cystoscopy, but if not, they stop. And they don't go on to get a potentially unnecessary cystoscopy. Those results aren't out yet, but I think this is promising from a screening perspective. Could we be using this to screen who really would benefit from a cystoscopy in the urologist's office versus who maybe were doing a number of unnecessary tests? And you know, anecdotally, probably of the cystoscopies I do a day for a new patient with blood in their urine, probably less than 1 out of 20 ends up having bladder cancer, and I'm an oncologist in my clinic. And so we're really scoping a lot of people who may not need to be scoped.
Yeah, it'll be nice when this becomes sort of standard practice, so that would be the definitive thing. Just pee in this cup and we'll test it, and then we'll see if we should go to that next level.
Yeah.
Yeah. So this is great. I know we have some questions. Just write them down. We're going to save them for the end, okay? Because I want to make sure we can get through. They have a lot of good information to share. So anything else on any of these other things?
I was kind of shifting to surveillance, which
Yeah.
I think is maybe the more exciting thing for the room. So now our surveillance is doing a cystoscopy either 3, 6, or 12 months apart for a pretty long time. For patients with high-risk bladder cancer, that can be up to 10 years. And so the real question is there a better way to do this than have someone come into clinic and get a cystoscopy every 3 months, which is invasive, is uncomfortable. For some people, it gives them peace of mind, and for other people, they dread those visits. And this is, I think, where patients' opinions really come in, because although we don't have a current biomarker that we trust in the urine to say, no way, you don't need a cystoscopy, I think we're close. But some patients may say, that's great, I want to use that biomarker, I don't want a cystoscopy. But I probably have an equal number of patients, I don't know, who would say, I'd rather the peace of mind of you looking in than to not. And so I think that we will take into account patients' opinions when these do come, because I think it's exciting. And so what you can see here is you pee in a cup, as we've been saying, and there are a bunch of tests that could be done on your urine. There's tests that are RNA-based, which are CX bladder, expert bladder. There's tests that are DNA-based, And then there's tests that just rely on the cells that you shed in your urine. So that's your traditional cytology, which is the most common one done, the most easy to get insurance to cover. And that's purely based on just cells shed into the urine. But all of these options are out there for options to potentially survey as opposed to doing a cystoscopy. And I think the advantage, as we talked about, is avoiding a cystoscopy. The disadvantage is, are we going to miss a significant cancer? The second disadvantage is you can have false positives, meaning it can say that there's something wrong and there's actually nothing wrong. And does that give you more anxiety to say, oh, there could be something wrong, but when they look, they don't see anything? Now what? Now what does that information have? And then, of course, in our healthcare system, cost is an issue in insurance coverage and things like that. And so there are guidelines to go back to, because you're going to say, why isn't my urologist doing these? They specifically say in surveillance for non-muscle invasive bladder cancer, a clinician should not use urinary biomarkers in place of cystoscopic evaluation. Now, these were from 2020. They're revising them, I think, to come out in 2023. It may change. It may say they could be used. And this is one of the things that kind of came out of COVID a little bit as one of the few positives, is some physicians around the country used an at-home test to decide if that person should get a cystoscopy or if they should skip it to avoid the hospital. All of these listed here are examples of urine biomarkers testing that can be done. And then I think this is the question. Do you want me? I can pause. I saw you writing and I saw your face. Oh, good. You're welcome. So one of the things that I think we need to know is, what comfort level does a patient need for us to not do the cystoscopy? And
we can do show of
yeah.
hands.
So how good? So would it have to be, for you guys, raise your hand if it would have to be at least 95% accurate. So only 5% chance that it's wrong. Okay. You want me to go higher? Yeah. What about 100%? Would it have to be 100? Okay, yeah, so there are some people. And then what about lower? Anybody who would say 90 would be okay for me?
No 90s.
And so that, I think, is pretty consistent. This is old, but this is from 2007, but they surveyed patients at Memorial Sloan Kettering and said, how good would a urine biomarker have to be for you to say, no, I'm not going to do my cystoscopy? And 75% of people, pretty similar to this room, said they needed it to be 95% or greater in order for them to feel confident that they wouldn't do a cystoscopy. And 21% actually said, well, 90 to 95 would be okay, which didn't really happen in this room. And so I think that is where patients' opinions are going to really be important, both in the development of good biomarkers, but also in personal decision-making with your doctor about whether you personally would use that over a cystoscopy.
What's the accuracy of a cystoscopy?
It's fairly reliable, actually. It's fairly good. The numbers are upwards of 95 to, with cystoscopy and cytology combined, it's over 95%. And so this looked at, if you were to do a biomarker, how many cystoscopies could you avoid? And they did this with 5 different tests. And what you can see is that you would avoid anywhere, depending on the tests, per 100,000 patients, you would avoid anywhere between 500 and 700 cystoscopies in 1,000 patients, which is a lot of cystoscopies avoided. However, you would miss about 15 to 80 recurrences, and the recurrence rate would be about 18%. And so what is more important to you is really the ultimate question. I think urologists would probably go either direction, but I think this is more of a patient question and a patient priority than to me at least, a urologist priority. I'm willing to look however you guys want me to look, as long as you know the accuracy of one versus the other. And so my kind of takeaways are urine biomarkers are here and they are improving. They're most accurate for tumors that are higher risk. So if you give a sample and it's positive, it's more likely you're going to have a higher risk tumor than a low risk tumor. But it may miss, as a result, low risk tumors or kind of those in between risk or intermediate risk tumors. Potential times to use it are if you get that annoying atypical cytology, which happens about 10% of the time. And that cytology that says atypical but doesn't say suspicious for cancer, what do we do with that? And that is also a point of concern for patients. And so perhaps doing a biomarker at that setting to say, yes, we should do more, we should do biopsies or look again, or no, this is okay, it was negative, can be reassuring. Kind of unanswered questions is, what if the biomarker is positive and the cystoscopy is negative? And that's where anxiety may come into play. Do we take every person who has a positive biomarker and a negative cystoscopy to the operating room and biopsy them? How do we handle those patients? And that's a puzzle for urologists. What is the risk and what's kind of the importance of not knowing if there's a low-grade recurrence or maybe a small high-grade TA in your bladder that we don't know about? And I think those are the things that are important. And I personally am not a big person. Cost is very important. To me, it's more important what patients pay out of pocket, but to insurers, it's going to be more important what they're paying. And so those are kind of the things I have for surveillance and about biomarkers new and what's improving. So go ahead, I think.
Yeah. Well, we've talked a little bit about that surveillance and screening, obviously. And, we've been dealing with BCG and a BCG shortage for a long time. The BCG shortage is something that's been happening throughout the last couple of decades, unfortunately. There's only one manufacturer. They're working to get a second plant built, which is going to be awesome. It'll help relieve that stress. But it was the earliest form of immunotherapy, and it became standard of care. I mean, tell us a little bit, how did it get started like that? Who knew that you could put Bacillus calmette-guerin in somebody's bladder and suddenly it'll take care of their bladder cancer? And then, you said that you're excited about alternatives to BCG. Tell us what they are. What's coming down the pike? We'd like to know.
I think what I am very excited about is when you have a recurrence despite BCG or that BCG refractory disease, which is not uncommon. It can happen, especially for those CIS high-grade T1s. It can happen like 30% of the time. So if that happens, don't be discouraged. That's not uncommon. But there are so many options after that point. BCG is still the gold standard, still the first line. But what follows are many more options than used to be. One option that is not actually in any trial, it's all been urologists putting their minds together and looking at their data, is a combination of gemcitabine, which is used for low-grade bladder cancer, and docetaxel, which is actually a type of chemotherapy they sometimes give IV. But it's the combination of these two medicines intravesical, so again, in the bladder. It's given the same exact way BCG is given, and it's given now for people who had BCG refractory disease, so cancer that came back despite BCG. And so those are people who you would think have a pretty aggressive type of bladder cancer. And what they found in patients like this who it was administered, about 60% of them went a year without any recurrence of their bladder cancer. And that persisted, about almost half of them, that persisted for 2 years. And of those who received it in this like small kind of multi-center urologist group study, only 15% went on to cystectomy. And again, these are high-risk patients who have a high risk of progressing to needing a cystectomy. And so this data is actually fairly positive for this. And it's fairly easy to give. The problem, I think the biggest downside is that BCG, you come in, the catheter gets put in, the medicine goes in, you get the catheter out, and you hold it and go home. The downside of this is they aren't actually given together, so that you get the medicine, you hold one of the medicines, then you drain that medicine, You have to administer the second medicine. So you're in clinic a long time. And a lot of people come a long way to get these medicines. And that is a pretty timely and more uncomfortable thing for patients to do than BCG, believe it or not. The side effects end up being relatively similar, but the time that you spend is more.
So you don't have a little shaker in the back room where you shake it
Yeah.
up and just put it all together. That's unfortunate, but I think it's important to understand that those are some of the other options that are out there.
Absolutely. And beyond that, there's so many more. I'm sure everyone here knows about Adstiladrin, nadofaragene for Adnovac. I'm just going to say Adstiladrin because that is way too long of a name, which is essentially like a type of a virus that, like a common cold equivalent, that you put in your bladder. And again, this is done in patients who have that high risk of recurrent disease. So they've failed BCG, BCG's failed them. It isn't working. It's not doing the trick. And this actually was just published probably 2 years ago now, 2 years ago. And it is given similar to BCG, but it's given once every 3 months. So it's not given weekly for 6 weeks, which is a positive of this. And they had really good response, particularly in patients who had high-grade TA or high-grade T1 bladder cancer that had recurred after BCG. Their complete response rate was 72% at 3 months, and about 30% of people had no recurrence at a year. And so this actually led to FDA approval of this, which is currently one of the only medicine FDA approved for BCG refractory disease. But it isn't yet available. It's available. It's being released at 30 sites around the country slowly over probably the next year or so. It's very expensive, and so it's probably only going to be located at certain healthcare systems. But it is an option, and it is being released. They're manufacturing it. It's starting to be released, and Vanderbilt will be one of the sites. I don't know if any Tennessee people here. There we go. We need more Tennessee people here. So it will be one of the sites, and like I said, it's again for people who BCG has not worked for them.
Right, so it's like a gradual rollout, and again, they're doing something to that virus before it goes in there, which triggers your body to fight off the cancer.
Yes,
and the fact that it is working for patients long term can be really beneficial.
Absolutely.
Yeah. So are there other major research gaps that we still need to know about treating non-muscle invasive disease?
Well, what I think it would be nice is urologists are a little behind medical oncologists in using genetics and things like that. And part of that is because it's a little less available in urine than it is in blood. But it is available in tissue and things like that. And so I think that is a future area. And I have a few slides. I think the next one might not be on that, but a few slides later, there are a few slides that talk about that. Do you want me to skip to those? Okay. This was me putting the plug that it's once every 3 months instead of weekly for 6 weeks. And I do just want to comment on this because this actually had truly probably the best complete response rate of all, and it uses a medicine with BCG, ALT-803. It was again done for BCG unresponsive disease, and basically it works by triggering your T cells, which are natural cells in your body, to fight off and kill the bladder cancer. It's given exactly the same way as BCG, weekly for 6 weeks. The complete response rate, again, in people with high risk of disease that has already not responded to BCG, was a 71% response rate. With a maintained complete response, which I think is important, of almost 2 years. And so at the 2-year mark, 91% of patients had avoided cystectomy. So this is really, really exciting. Also, I think being worked on through the FDA and FDA approval, which one of the questions I think Stephanie had written down there was, how long does that process take? It seems like a very long time. I personally do not know, but they audit every study. The FDA audits every study that is done. After they get done with the audit, they convene. Meet with the company. They do all sorts of things. I think it is extremely timely. And so unless you get expedited approval, which who knows how that happens, it takes some time.
Yeah, it's a slow and gradual process, again, sort of like steering the Titanic. It takes a while to make it turn. But
Yes.
The good news is there are a lot of people paddling on one side to try to get that turn to go a little bit faster. And, one of the things you use the term a lot, high risk versus low risk. And I think most people kind of get it, but maybe we just clarify. That's something that's looking at that very first tumor sample that they take out with that TURBT, correct?
Yes. So low risk are tumors that are low grade under the microscope deemed by pathologists that less than 3 centimeters and low grade. And those kind of fall generally into the low risk category. Then there's the intermediate risk category, which is if a low grade tumor is more than 3 centimeters, or if you have recurrence of a low grade tumor, or if you have a small, less than 3 centimeter high grade TA tumor. The high risk patients are those with high grade T1, bladder cancer, carcinoma in situ, or very large bladder tumors. Those kind of, broadly speaking, fall into the high risk category. And so for low risk, in many cases, we're actually surveying with no further medication. In intermediate and high risk, we're usually giving some type of medication. And then once you have recurrence after BCG, that kind of, it's almost like a very high risk category, and that's where our mind is triggered. Something could be more aggressive about this person's cancer, and we try to get aggressive with how we treat it. Usually first, I think what's important to know is BCG refractory by most of these studies means you got 6 BCG treatments and 3 maintenance, or you got 6 BCG treatments, didn't work, and you got 6 more BCG treatments. And so it doesn't mean you got 1 round of BCG and it didn't work. It means you got either 9 treatments or 12 treatments and it didn't work.
Yeah, so you got the whole package and it didn't do anything. Or it might have worked for a short while and then it came back.
Yes.
So remember those dandelions. They can really be annoying. Okay. Great.
And then this is like a very busy slide, but it was kind of intentional because I want to show you like all of the things that are happening in non-muscle invasive bladder cancer. So one of the things that is happening in the low grade tumors that have come back, but they still you're presuming they're low grade, is mitomycin gel, which is like a gel you instill into the bladder and it kind of solidifies, so it makes it dwell a little bit longer, and then you urinate it out. And it's actually thought to kill the tumor without having to have the tumor removed. And so this study actually, 65% of people had a complete response at 3 months and 61% had a complete response at 12 months. And that is, again, without them having the low-grade tumor removed. So it's a chemoablative, so killing what is there without having to go to the operating room. So that is exciting, again, on the horizon. The next one I have here was exciting. This is where urologists finally are getting into genetic things. And so this is, I can't say that, but pemigatinib. Good luck. I think that was about right. And it's being used for, again, low-grade bladder cancer that has kind of either come back or is new in someone who has something called an FGFR3 mutation, which is a special mutation that is commonly found in low-grade bladder cancers. And it is given orally, so it is a pill. It is not an intravesical therapy, no catheter. And so what they're looking at is the complete response rate, but also the safety. Of course, everyone gets excited when you think of something administered orally, and I think it's, yes, it could be very positive, or it could be, are there side effects that affect your whole body instead of just your bladder? We'll find out. And then again, in intermediate risk bladder cancer, so high-grade TAs, again, this is in people who haven't tried BCG yet. They're looking at another oral option, and that's exciting. Again, oral options may be exciting. And then the high-risk patients, and there are a bunch of studies going on in people who haven't had BCG yet with high-risk bladder cancer. one of the things that we've talked about is the BCG shortage. So they're comparing one strain of BCG to another strain of BCG with or without a little vaccine. And they're comparing that to see which is better, if using the little vaccine helps BCG work a little more. And then they're comparing the BCG and that chemotherapy I mentioned earlier to see, hey, if BCG suddenly is gone, can this chemotherapy be used as well as BCG? And then there is the little pretzel. Has anyone heard of the little pretzel? So there's a pretzel that you put in the bladder. It looks just like a pretzel, and it slowly gives off a medicine called gemcitabine, and they're actually coming out with a new one that slowly gives off a medicine called erdafitinib. And the thinking is that if it slowly gives this off, is it going to result in better outcomes than just holding it in for 2 hours and peeing it out? And that little pretzel stays in your bladder for 3 weeks, and then you take it, it gets exchanged by cystoscopy. So you're getting a cystoscopy every 3 weeks, but you're not getting a catheter once a week for 6 weeks. And so that preliminary data showed that 72% of patients had a complete response, no recurrence, with that little pretzel at 11 months. And then there's tons and tons and tons of studies looking at BCG with immunotherapy, the kind of immunotherapy that you get in an IV systemically, where Dr. Beckerman would be the one who's doing that for me, and I'm doing the BCG. And my final slide is just all of the trials that have come from 2014 to 2025, anticipated end dates. This was presented at our American Cancer Society type meeting, and you can see all of these options. I mean, there are so many options for muscle-invasive bladder non-muscle invasive bladder cancer that are being investigated, that you should be very excited. If BCG stops working, or if you have low-grade recurrences, I think there's so many things on the horizon that are going to be successful.
Yeah, so for all of you that are hanging out at that base of that iceberg that I showed you, the bulk of bladder cancer patients, I think this is sort of like the way that you depicted it here. Think of it as the rainbow to the pot of gold, that there's going to be more options coming up because brilliant people are working on these things, and I think it's really exciting. Again, putting medicine in the bladder that it goes against the tumor is really the best way to attack tumors that are on that surface, because it's impermeable to other things. It doesn't just let things that aren't supposed to go into your bloodstream back in your bloodstream. So they have to treat it that way. So that pretzel and that mitomycin gel basically keep that medicine there for an extended period of time, whereas you can only hold it so long, right? We know this. It's a challenge to hold it BCG for 2 hours. For some people is a real challenge, especially when they fill your bladder full of that stuff. It makes it really hard. So this is another way of drug delivery that kind of stages it over time so that you're getting more of that exposure. So there's real promise out there.
There is, absolutely.
So are we good on the non-muscle
Yeah,
invasive?
I think so.
All
Yeah.
right, let's talk
Pass
now.
it
This is
along.
an opportunity for both of you to get engaged. I do want to just point out that sometimes treating muscle invasive disease requires a surgeon, a urologic surgeon, and a medical oncologist, and even in some cases, particularly when you're trying to keep your bladder intact, it might involve a third medical professional, a radiation oncologist. So let's talk a little bit about the standard of care for muscle invasive, sometimes included chemotherapy plus bladder removal. Is that the only option today?
Yeah, so I think I'm on. I'll say that this is another reason why I love coming to work is because we get to work together so closely. And specifically, I think it's really in patients who have muscle-invasive bladder cancer, and we're often calling each other saying, "Hey, I've seen someone; they need to come talk to you today." And I do think that there's lots of exciting research going on to what could be added, what could be changed for what we call neoadjuvant treatment, and the standard of care has been and I think right now continues to be a cisplatin-based chemotherapy. But some new data certainly coming out about whether or not we can, with all these different trials and some of the medicines I'll talk about, add immunotherapy before or after, or even the drugs that Amy has spoken about, as far as essentially we use this medicine, and many of you are likely already familiar, but to understand that in muscle invasive bladder cancer, where that cancer has shown it's become sneaky, it's moved beyond that initial layer into the second layer, which makes us all very worried that the curative intent surgery or radiation, there's still this high risk that it could come back. And so by giving myself, I give medicine ahead of time, hopefully to try to either downstage, make the surgery easier perhaps, but mostly to try to say we want to keep these cells from setting up shop somewhere else and coming back after a curative intent surgery. But I would say that right now still kind of cisplatin really remains the current standard of care.
So you give that by IV, so it's systemic, it goes throughout your whole body, so any rogue cancer cells that might have broken away are likely to be captured and killed that way. It's sort of like spraying weed killer down after you pull out your dandelion, that tumor that you didn't like. So it's helping in that general area. Or I like to use a lot of analogies. To me, it's sort of like this neoadjuvant before, say, bladder removal surgery. You put the evil genie back into the bottle before you throw the bottle away. So you make sure that all the genie goes back, that there's no genie left anywhere else to cause problems.
Yes.
Okay, good.
I like that.
Yeah. Okay. So who's eligible to maybe not have their bladder removed, but try something else? Because it's not, most people say, I don't want to have my bladder removed. That's not an option for me. I just don't want to go there. But maybe that's not an option for you. So who would be eligible? Who is a likely candidate for, say, bladder preservation that uses surgery to remove what they can of the tumor, chemotherapy, and then the additional radiation that comes in from the radiation oncology team?
Do you want me to do part? Okay. So when I think of this as if it is only into that muscle, if it's a T2 or stage 2, and it's a single tumor, those people are actually pretty good candidates for chemo, radiation, and TURBT, so scraping it to remove it. They have to be aware, if they choose that, they get cystoscopies every 3 months for 2 years, every 6 months for the next 2 years, and then every year. And scans are about at that same interval. If it's a patient like that, about 10 to 20% of people may end up needing their bladder out at some point. If they have worse than that, so if their kidneys are swollen and not draining well because it started to grow deeper than the muscle, or if they have carcinoma in situ, it's not very radiation responsive, they aren't great candidates for that. And so I certainly talk to patients about it and try to give a pretty unbiased opinion. But I think for young, healthy people, I often favor, especially because they have more years for this to potentially come back, I often still favor the surgery and chemo. If it does come back and after the trimodal or 3 treatments, surgery is a little trickier, especially in a man, because it is like super glue's been poured in the belly, and when we go to remove the bladder and prostate, there's a higher risk of injuring the rectum. And a higher risk of needing a colostomy, so 2 bags, a conduit and a colostomy. Not to scare anybody, I'm just giving my talk.
So that super glue is when they're shooting all those radioactive beams in there. It's causing some scarring.
Yes.
It's causing what they call adhesions, where things get stuck together, and that's really what.
Yeah, and it's not a high risk, but it's about in the cystectomy that's a fresh bladder removal. It's about a 1% chance or less of injuring the rectum. In someone who's had radiation, it's about a 10% chance. So it increases pretty significantly. If you're not one of those 10%, it's not that much. But if you are one of those 10%, it sure feels like a lot.
So are there a lot of trials that are happening that are working to develop or examine some options beyond just removing the bladder?
I think you have a slide on that, right?
Yeah, I think a lot of the excitement is around this idea of, can we use a biomarker to understand after neoadjuvant, that means treatment prior to either surgery or radiation, whether someone needs to proceed with that. So I'll show in a little bit that ctDNA, either from the bloodstream, so just taking a blood sample like you were getting your normal labs, and looking for mutated DNA that's being shed by the cancer, either in the urine or in the bloodstream, and using this as a way to say, okay, maybe the chemotherapy did an amazing job. Do we need to still proceed with a major operation or a surgery? So I think there is a lot of excitement to try to better understand and still treat aggressively. We want to go for cure, but also minimize, any interventions that we don't need to. Yeah.
Okay. So for patients who are at that stage where they need to make decisions about their treatment, should they consider going into a clinical trial as a treatment option? What is your opinion?
Yeah, I'll start and Amy can add on. I always try to be upfront and honest about every part of a clinical trial. I also try to educate what it means to be in a clinical trial. So always, a clinical trial for any patient who has bladder cancer is at least offering the standard of care and then trying to do something more, right? You're always at least getting what we would have done otherwise, plus trying to advance treatment, improve cure. So that's always the advantage. So if we have a trial, I'm always trying to say, okay, we're at least going to do this, but this clinical trial offers this additional option. I also recognize clinical trials are not for everyone. They often do involve all the treatments then have to be done at that center where the clinical trial is. And so if you have driven into Vanderbilt from East Tennessee and that was a 6-hour drive and the trial requires you to come once a week, I mean, that just might not be feasible. So, but even then, clinical trials sometimes offer like travel support or things. But yes, I highly encourage entering a clinical trial.
I completely agree and describe it in the same way. It's at least standard of care plus a little something more in most cases. And I think that clinical trials are how we get all these new exciting drugs out there. And so, it would be nice if we all could play our role in helping that if that opportunity arises.
Right. So, a lot of people are interested in making a difference, but people are a little leery sometimes. And there's a myth that's out there that I think many people believe. They're afraid that participating in a clinical trial means they're going to get the pink sugar pill. We all remember enough about high school chemistry and biology and all of those classes saying, yeah, somebody's going to get the placebo. But that's not the case in cancer. And, we keep trying to remind people about that you're always going to have, as you say, at least standard of care. There are pros and there are cons for all different clinical trials. But if you don't ask, you don't know. So I think, that's a big deal. And especially when you're not being seen in a large academic hospital where they might have many clinical trials, but maybe your doctor's participating in just one or two. If you don't ask, they won't even sometimes bring it up. So I think it's important if you're interested to find out. It gives you closer monitoring, potentially access to something new and maybe really significant. And then you can also always get out of it if it's not working for you. You don't have to make a commitment for the rest of your life, however long or short that is. You're not bound to that clinical trial. Yeah. You can always say, this isn't working for me, I'm going to step away. I think those are important messages.
And if you want to find some, the clinicaltrials.gov is a website, and you can search like non-muscle invasive bladder cancer, and every clinical trial for that will come up, or muscle invasive bladder cancer, and you can click on each trial and it will say what sites exist, and things like that if you are interested in looking for that.
Yeah, which is good. But as I think I mentioned the other day,
Yep.
yesterday to you, sometimes when you go to clinicaltrials.gov, it's a bit like getting a sip of
It's a
water
lot.
from a fire hydrant.
Uh-huh.
So
Even
we
for me.
take those same clinical trials from clinicaltrials.gov, and we take them, and it's only clinical trials for bladder cancer that are open and recruiting in the U.S. And I will tell you, it's a lot more zen when you see how we do it than how clinicaltrials.gov does it. So we have a clinical trials dashboard as well, and you can look for clinical trials in your neighborhood, in your area or your state, by disease, or by some place that perhaps you have a relative that you could live with for a while and be part of a clinical trial. So it gives you options at the Beacon website. Okay, so should we move on to some more advanced disease stuff? So do you want to change
sure.
your slides? What is the standard of care?
Oh,
Sorry.
yeah, it's fine.
Yeah, so
For advanced disease, like locally advanced. Let's start with that perhaps.
yes. So this is, I think, I've listed here all the exciting things going on. Amy's talked about a number of these. I've already mentioned. So what I tried to put in like some historical context. We all understand that bladder cancer is very complex, and we have tried to develop our treatments based on the biology of what drives bladder cancer. So on the left, it's basically saying we know that we start with normal cells, but as you move through this diagram to the right, each stage going from a change in the growth of the cancer cells, and then as they move through the different layers, basically come with increased complexity is just maybe the easiest way to say it. And so it is hard to just say, you're a patient with bladder cancer. We recognize every patient has a different mutation profile, but we're still treating everybody all the same. We still give every single person all the same medicine. So I'm hopeful as we go along that understanding genomics or things might tell us, oh, you need this medicine. We can treat your cancer in a specific way. Again, here's kind of the historical perspective, and just really to highlight and emphasize why we are so excited in just the last several years. The top agent there, that CDDP, is cisplatin. That has been the standard of care since the late 1970s. And while we are certainly very appreciative that it does the job that it does, to have been using the same medicine for the same number of this long, I think just gives you a sense of using one chemotherapy, and then over time, 1995, combining that chemo with a number of other chemotherapies in either locally advanced or metastatic disease. And then we said, well, maybe these couple therapies aren't the right one, so we're going to mix it up with some other chemo. So basically, we spent 30 years mixing different chemotherapies. It's great, that's good, but we recognize chemotherapy had some incremental improvements. And then really here in the last kind of 5 to 10 years, we've seen different ways of fighting cancer, not just chemo, but different ways of fighting that cancer. So what I would have said, if we had all met 2 weeks ago, so that's why I highlighted here, 2 weeks ago, the standard of care was to still use that chemotherapy that we've been using since the 70s. And then we knew we could improve survival. So that's what this clinical trial was called, Javelin 100. And they basically did chemotherapy, standard of care, and then switched the way of fighting cancer with immunotherapy. So we've had a number of immunotherapies, 4 or 5, and then it's altered a little bit, but showing response in bladder cancer. And the thing we really know about immunotherapy, which is an IV medicine that activates your immune system to fight off cancer, is immunotherapy is currently one of the main methods that we know can sometimes get a cure even in an advanced setting. So that's, of course, what we want. So they said, sometimes, we're smart, but we're not really that smart. If you take one medicine that was working and you add another medicine in that was working, let's see if that works together better. And it did, which was great. So this has been the standard of care. Use chemo and then switch to an immunotherapy. In this instance, it was an immunotherapy called avelumab, and we call that just switch maintenance in case you ever hear that phrase. And so this is the improvement that we had seen compared to what we were doing before. In that it's called BSC alone or chemotherapy alone. The average median overall survival for a patient with metastatic disease was about 14 months, and we improved that just in the last 3 years to be closer to 2 years. I wished it were more. I always want more. We always demand more, and so we're continuing to do clinical trials. And these 2 trials reported out just a week or so ago and have been exciting for us, and I think will start to change standard of care therapy. So instead of starting with chemo and then switching to immunotherapy, this is the first trial that showed let's do them all together, all up front, and we think it may be captured to help more people. So this was a new trial that just presented out. Has about maybe the same average in terms of overall survival. So, but still exciting because I think we're capturing more patients who get this benefit. So I think that's the difference here. And then I wanted to introduce what this is because it's kind of a targeted, I'm going to call it a targeted chemotherapy. It's an antibody drug conjugate. So up on the top there, it says what it targets. So there's one that's FDA approved called enfortumab vedotin on the right, or I guess on your left, and then sacituzumab govitecan targets something called TROP2. So these are basically little things that stick out from the cancer cell surface. So they should go right to the cancer cell. They don't trying not to hit all the normal cells in your body, just hit the cancer cell. But then they deliver these things at the bottom, and those are essentially different ways of delivering chemotherapy. So still some of the same type of side effects that I've listed here, like you might have lower white cells and could get a fever, or you might still have kind of nausea and diarrhea with these medicines. But the reason this has been these new medicines, we've been using them after someone has progressed on chemotherapy up front. And this data is what was most exciting and has just changed standard of care essentially, like literally last week. This clinical trial was a phase 3 trial that took that antibody drug conjugate, so targeted delivery of chemotherapy, and combined it with an immunotherapy that you all may have seen advertised on TV called Keytruda or pembrolizumab. They compared that to patients who had been getting 30 years of standard of care chemo, and we saw an improvement, again, for the first time in overall survival from what had been 21 months to now 31 months. And also highlighting, that's what that curve there is on the left that I've got the red box around. And then on the right, what's also really exciting is that this trial just reported out. It's still early in follow-up. You know, we'll have hopefully years and years of information. But that chart there on the right, the dark area that says CR, that's patients who had complete response. That means there's no evidence of their cancer on future scans. And we hope that this is, you know, long lasting for these patients, even representing the potential for cure. So this was practice changing. When this data was presented there on Twitter, there were people with standing ovations. This is just so I have goosebumps sitting here talking about it now. So again, 2 weeks ago it was still an improvement, but here we are continuing to push forward, hoping to continue to increase cure for patients. And of course, we're excited for that improvement. We recognize it still comes with many potential side effects that, you know, talking to your doctor about, being educated about what could potentially come so that you can call in and say, oh, I'm having a new skin rash, or, you know, we talk about numbness and tingling with this medicine. There's certainly side effects. I recognize this is not a benign medicine, but still the efficacy is wonderful to see. This clinical trial just reported out in the last month or two, and it has I think the median. So the actual drug enfortumab vedotin has been used for a number of years. It's been FDA approved for 2 years, but we've been using it in later lines of therapy. So, for example, people who have already progressed on chemotherapy, and they basically said, well, could we make it better by moving it earlier, making it the first treatment that somebody gets, and combining it with immunotherapy? Does that help? Okay. Yes.
If somebody does experience what we call adverse events or side effects, from something, is it possible to switch?
Oh yeah, certainly. So I think we do a lot of education of you can always start a medicine, and if you don't feel well or you just can't tolerate, that we switch. The one caveat to that I always educate my patients about is that some of these side effects will go away. For example, with chemotherapy, if you stop the chemo, your white cells will come back up. But with immunotherapy, if you get a side effect from immunotherapy, it probably means you've activated the immune system. It's fighting your cancer. That's great news, but you've gotten a side effect. And to make that side effect go away, we have to quiet the immune system. And so sometimes that may not always be reversible. So yes, we would stop it, but sometimes some of the side effects, at least from immunotherapy, can persist.
Yeah. So a lot of these are looking at targeted things like FGFR mutations, or TROP2, or Nectin-4. Should everybody expect to have their tumors typed so they can understand if they have these mutations?
Yes. So that has changed, and I think mostly for the FGFR mutation. I hope it'll be more and more things as we're learning about how can we target different mutations. But in our practice, the very first time that you're coming in, we're doing genetic testing, and it is really specifically, we can learn other things about the biology of a cancer based on this genetic testing, but it's also to see if you might be a candidate, if you need it in the future, for a medicine called erdafitinib. I forget if that's my next slide. It is. That was great. So there's this mutation that exists, and Amy spoke about it. We recognize that there's this receptor, that's that cloud picture there on the left, called FGF, fibroblast growth factor receptor. And it's pretty common. On the right-hand side, I'm trying to show you that in that bar on the left, it's kind of it's like the green area and that orange. So it's like more than half of patients have this FGFR. And so we recognize it's really important in maybe initiating that bladder cancer. And as patients go further along and the cancer maybe changes to become a stage 4, maybe less frequent for us to see those, but we still test for them, because if you have that, in that little yellow box that is highlighted, there's a pill medicine called erdafitinib. And again, Amy's even using this in non-muscle invasive clinical trials. She mentioned the oral, I think it's pemigatinib, and there's various companies, trying to target this. So right now I sequence everybody the first time that I see them, but it doesn't affect what I give them in the first treatment. It only tells me, okay, later on you might be a candidate for erdafitinib. And that was based on this data. If we take this pill, erdafitinib, for patients who have this specific mutation, a number of patients did well and controlled cancer for a long period of time if they'd already progressed on chemo and immunotherapy. And again, this is, I think Amy said it really well, in the non-muscle invasive space, we know in the metastatic setting it has side effects. And so I think it'll be a challenge of how do we manage side effects and try to see if this is helpful and represents improved response earlier in disease.
All right, I have another question for you, because I know we did a little survey early on. Big portion of our community here are seen in their community practices. I know that Vanderbilt Hopkins, Memorial Sloan Kettering, a lot of the big academic hospitals make it standard practice that they're going to do genetic testing. But you get a lot of referrals from the community. Do they come to you already knowing what their genetic profile and mutations are, or do you then have to do it there so that they're not getting the benefit of these things in the community?
I really feel like that many of our community clinicians are doing this as well.
Good,
You know, it might
good.
not be right the very first time you meet your medical oncologist or something, but I just saw a patient yesterday, and I didn't have to say, oh, we need to get mutation testing. That had been done.
Nice.
So, you know, it's insurance approved. It's in our guidelines. And so I think many people have already had it done.
That's encouraging because we know people can get really good care in their community, but I just wanted to see, is it something you can only get, you know, this level of care at a large hospital, academic hospital, or can you do this in the community? Because it does take a while to trickle down to people that are doing it maybe every once in a while, not as often as you do.
And just to comment on the non-muscle invasive space, it is not insurance approved. It is specifically for advanced cancers that it's approved and recommended by guidelines. So community urologists are not going to be doing this. And if you came to, say, somewhere like Vanderbilt or Hopkins, or they may do it if they are using a targeted therapy. So for non-muscle invasive cancer, everything's a little slower to pick up. I think we'll probably head that way eventually, but for non-muscle invasive disease, that's not currently the standard of care.
Okay. Good. Yeah, one of the questions was like circulating tumor DNA. Can it be used to diagnose? How do you go about getting this done if this is something you think is beneficial?
Yeah. So I've listed here, you know, a number of different things that we continue to look at. On the right-hand side, all these cool-looking charts are basically that, you know, kind of since 2014, so it's been several years, we've learned that bladder cancer can be subdivided, the biology of it, kind of how slow or how fast does it grow based on these different mutations. And they labeled it different genomic categories. But right now, it's not something that I get and I use to change my treatment decision. And so some of these other factors, same thing, we get them, they help inform us about how the cancer might be growing, or maybe on PD-L1, how likely you might respond to immunotherapy, but they don't necessarily change which treatment right now that I'm going to pick. The only exception there being that FGFR, you know, mutation. But I do think that there is this excitement about ctDNA, and what ctDNA is it basically like the blue dots there on the top represent the cancer, and that the cancer, as it dies or breaks off, can leak the DNA that it had within it into your bloodstream, or if your cancer happens to be in your bladder, it can leak it into the urine. And then we can look for this specific DNA because it's not like your normal DNA. It has mutations in it that are unique to the cancer. So this was actually first used for women who were pregnant and they were looking for mutations that maybe the baby had. And so it's actually been a test that's marketed and used for a number of years, but now we got smart, not myself, many other individuals, and figured out we could do this because the cancer cells have specific mutations that we can look at. And so right now it is not, I would not consider it standard of care to make a treatment decision, but there's lots of excitement going on. So for example, this is a clinical trial where we said we collected patients were kind. They got this therapy, this immunotherapy, but they also gave blood samples so that we could look and see did they have ctDNA. So on the left, on the top, those patients did not have any ctDNA. They'd had surgery. There was no ctDNA. So maybe those patients were unlikely to have any cancer cells in their body. On the bottom of that chart, those patients had ctDNA. And we looked, well, if a patient had ctDNA and got immunotherapy after their surgery, the curve in blue showed an improvement in what we call disease-free survival in keeping that cancer away compared to the patients who did not. So basically saying maybe we can start to use this type of biomarker to decide who needs, based on ctDNA, some treatment after surgery if we're seeing this kind of chance that a little mutation is still present in the body after surgery. So that's what, there are many trials out there. I'm highlighting just one, but basically that's what they're doing, is they're saying we're going to give treatment based on ctDNA and see if that's helpful. And then, oh, that was my last slide.
This is good. So we'll be sharing the slides with
Okay.
you as well, as I mentioned before. So you've given so much promise, you know, given people a lot of hope, I think, and a lot of patients trust their doctors. But if you wanted to know, like, what is the best way to bring this up with your doctor? If you're open to this at this large academic hospital, but many patients are being seen in their community, what's the best approach to take to say, hey, what about this? You know, what do you recommend people do?
Yeah, you know, I always have, and I love it. I don't know, I love it when people come in and say to me, oh, I've heard about this new exciting thing, or, you know, what do you think about this data, or should I be, you know, checking on, I mean, I'm sure maybe there are people who do not, but I think most of us really enjoy talking about that. And I also always advise many of my patients, even though we're at a large academic center, to get second opinions. Second opinions, not only do you get to hear maybe the same information even, but said in a different way, so I think that's helpful. But also if you go to another place, and especially if you're looking for a clinical trial, each of us have different trials open. So Vanderbilt may not have the same trial that University of Kentucky or MD Anderson, or, you know, if you have family in one place, you know, that you might go to Baltimore and go to Hopkins because you can stay with someone. And so I think getting a second opinion and talking to your doctor, I don't have many times when a patient comes into me and says, well, my local doctor wasn't receptive to this. You know, it's never, I don't think, seen as a ill-intentioned, you know, but just that we're all working together.
Sure. Yeah, sometimes that second opinion is the same thing your original doctor said, and it's like, okay, two people are now telling me this is the way to go. Maybe this is what I should be thinking about doing.
Yeah.
Yeah. Dr. Luckenbaugh, anything else?
Yeah, no, I completely agree. I think, and in the non-muscle invasive space, I think if bladder cancer comes back after BCG, I think it's the habit of many community urologists to send to a larger center to see if there's trials, to see if the bladder should be removed. I think if it comes back and your urologist immediately says you must have your bladder out, it is worth saying, are there any alternatives once BCG has failed? And if so, where are they? How can I get them? And I don't think if they take offense to that, then that's their issue, not yours. And that you should, yeah.
But what if they're not aware? If the doctor, every urologist can't be up to date with everything that you both are doing. So, as a patient, I wouldn't think, oh, is there, okay, I failed my first shot with BCG, what do I do now?
I think that, and maybe I'm dealing with different community referrers, but I think that most community urologists will send people usually at that point, even if they aren't aware what trials we have open, they will send for the consultation about bladder removal. And if that's what they're sending for, and it's a non-muscle invasive cancer, I usually step back and say, whoa, we might have a bunch of other options available. I also think this is where your use of the Beacon website may come into play, because you can say, hey, I read this. Do you know anything about this? If not, do you know where I could find out information, or do you know who may know more? And they shouldn't take offense to that, I don't think. Yeah.
My feeling is they do, it's time to find a new doctor.
I'm with you. I'm with you.
So now I want you to imagine this monitor is a crystal ball. What do you see in the future? Or what are the critical needs that you think should be addressed in the future?
I think that we will probably at some point be doing less surveillance cystoscopies. I do. I think they may not go away forever, but maybe alternating with urine biomarkers and every other visit is a cystoscopy. I think that probably is coming. I think delaying or avoiding cystectomy or bladder removal is coming. And I think, can you go back to your last slide? In the muscle invasive space, I think that this is coming. This trial, they're giving 3 treatments for muscle invasive bladder cancer, and then they're all like systemic, so nothing, no surgery, no radiation yet. And then they're going to look in the bladder. If there's nothing there, and there's like no ctDNA or anything going on, they will not have people undergo bladder removal. And if there's stuff there, they undergo bladder removal. And I think this is probably coming because we know that when we take out a bladder after chemo, 25 to 30% of the time there's no cancer left. And truly, those are the people who do the best. That's exciting, but also in the back of every patient and every urologist's mind is, did we really need to do that? And right now we don't have that information to know, no, we don't need to do that, and maybe in the future we will have that information.
Yeah, I think it'll give confidence. If
Yeah.
you know that you can see that there's the potential for that cancer to still be there, or there's really nothing there, then that gives you confidence in letting that patient go forward with their bladder.
Yes.
I think that's great. Okay. We have time for Q&A. So if you want to raise your hand, we've got our microphones coming around. So we'll start on this side, and then we'll go to that side next. So let's get this first one.
Yeah, hi. I just was wondering if you can go back to the slide where Dr. Sherry Jeanette was listed and Dr. Harry Har.
Oh, yeah.
Oh, pull it at you.
Maybe. Slowly, I will get there.
Remember, I will make these slides available to everyone, so don't stress about you just wanted that slide. You know, if you have a particular question about that, there's the slide. Okay. Do you have a question about it?
Oh.
Oh, okay.
They're great doctors.
I have a question on this side, though.
Yes, I've been on Keytruda for the last year, and prior to that, I had all positive cytologies for years. I've had 2 consecutive negative cytologies with this medication. It is truly almost miraculous. They wanted to take my entire urinary tract out before we started this, and I said, no, that's not a viable option for me. I don't want to have my quality of life destroyed. So we started Keytruda. My question is this. I'm almost a year into it. I'd like another year or years of this, if need be. I've had minor issues with it. I mean, as far as, some negative things, aspects of it. So I'm wondering if you can answer for me how long I should tell my doctor back in Denver that I want to get this, because, you get a little pushback with this stuff. It's very expensive. And then are you finding that people who've been on Keytruda, is this a cure? Are they getting cancer again after being 1 or 2 years? I don't know how much you know. I mean, you must know plenty about this, but.
Yeah. So, I don't think either of us actually talked much about the use of Keytruda in the non-muscle invasive bladder cancer. And for a period of time, it was, besides BCG and then really kind of gemcitabine, because it was before we were even doing, or you all were doing, combination intravesical chemotherapy, it was one of the only other options in patients who had failed BCG. I think it certainly can represent a cure, but I would caution to say that it, unfortunately, in the clinical trial where we have the most data, it was a minority of patients. And so because unfortunately many of those patients ultimately did go on to have either a repeat cystoscopy that showed that the cancer was ultimately coming back or changing. So for that chance, right, of potential cure, I think it is a wonderful medicine, and I do still give it in that state, now. But I'm very cautious and calling Amy and saying we've got to repeat, we've got to follow closely, because I often can't follow it on a CT scan. Only she can see whether the cancer is changing, on a cystoscopy or, as you said, a urine cytology.
Do you recommend continuation of the therapy as long as the cytologies are negative?
Yeah, so I think that is an excellent question, and one to certainly be had with your provider. And the reason I'm going to be so vague is because even in the metastatic setting, we don't know when enough is enough, because the clinical trials are often done, for example, they stop at a certain time point. So they may stop at 2 years. And we recognize that the immune medicine is a little different than like chemotherapy. Once you stop chemo, it goes out of your system pretty quickly. If immune therapy has had an effect, there is the hypothesis, the idea that effect could persist even without getting more treatment. And so that's why I say we don't really know how long to continue things. We always base it on the clinical trial that got the FDA approval for it. So for example, if Keytruda was given for 2 years in a study, then the standard FDA approval becomes 2 years for that study.
Are you saying 2 years then is what you're recommending?
No, I am not recommending anything specific for any individual, because it really does become a point of discussion of like, oh, you've had a really serious immune-related side effect. Maybe this is not something safe to continue after.
Well, I've not had that.
Well, a follow-up question to that, Katie. Now that these immunotherapies have been approved now for 7 or 8 years, is anybody looking at long-term? There, I'm sure, are some patients, I know of one in particular, who said it's not broken, we're not going to change it, it's working, and ended up having some long-term complications. Are there any studies that you know of that are looking at long-term use of immunotherapy and the complications that could come out from that?
Yeah, so I think there are some studies in other tumor types. I'm not aware of one in bladder cancer right now that's looking at the timing of when to stop, or if you stay on longer, as you just said, the potential for delayed or late toxicity. But in melanoma and kidney, there are some studies going on looking at this.
Okay. Any other questions?
Yes, I'd like to thank you both for a wonderful presentation. I have a question for Amy. You mentioned that for non-muscle invasive bladder cancer, that genomic testing is not covered by insurance. What is the estimated cost of genomic testing? And you think at some point the insurance companies would cover that? Being that, you nip it in the bud early, you would think that the cost would be a lot less overall.
Absolutely. You can negotiate with the companies with that information. But yes, so I do think that they will eventually probably cover it, specifically as more targeted therapies come out that are available to treat it, because that will give them ammunition to say, well, we need to know if they have this mutation, because this medicine could nip it in the bud and make it go away. So I think eventually they will. They may be selective about only doing it in select patients. For example, those who have BCG refractory disease and recommend like a high risk. They may start with a group like that. They often start with the group that is the most serious and then move down to the group that is the least serious by their judgment.
Great, thank you very much.
Of course.
I'm wondering, I just moved into the metastatic level last week. At my appointment, I received news that I had Addison's disease and had to stop immediate immunotherapy. Does that mean all immunotherapies that they have out there are going to be, or at the appointment it was pretty much in shock. I didn't have the questions to ask.
Sure. I certainly understand that. We do worry that most of the immunotherapies that we have available right now, they're kind of made by different companies, but they target pretty similar things. They target this PD-1, PD-L1 interaction, and so the risk of any of them are still similar in the sense that if you were to retry Keytruda to Opdivo or Opdivo to avelumab, they all can have the potential for immune-related adverse side effects. And so I think that certainly to have that conversation, with your doctor about is this something that I need to try again in the future, or would it be safe, is certainly something to think about. Yeah.
Should they consider switching to like an antibody drug conjugate or something along those lines?
Yeah, I think it kind of depends on maybe what the cancer was doing. If you're on a medicine and the cancer shows on a scan or something, a progression, then, and plus maybe having a side effect, then I worry, well, maybe that medicine wasn't controlling the cancer like you wanted it to. You've had a side effect. Let's switch the way we're fighting the cancer. As you mentioned, to either an antibody drug conjugate, chemotherapy, or a targeted therapy.
Now, the good news is the teams of doctors now have more tools in their toolbox than they ever did. So it's always nice if the screwdriver doesn't work. Maybe they need to take out the hammer. I don't know. But they can try something else because there are other tools. And then there's some of the MacGyver tools that, you try a little of this and a little of that and shake it up in the cocktail shaker, and then we'll try that. So the good news is they're always working on it. Next question.
Yes, for non-muscle invasive, how would you prioritize if BCG treatment fails, the natopharogen versus the gemcitabine and todoxetal, or whatever however we say it? How would you rank those two?
Truthfully, it's going to be what you can get. I think what's most important is getting it started, not necessarily one is greater than the other. Starting with the gemcitabine docetaxel, if it's available, which it is right now and the other is not, would be probably my go-to. I don't think there's a ranking, truthfully, in all honesty. I would probably start with the gemcitabine docetaxel simply based on availability, ability to get it reliably, which right now isn't yet quite there.
And if you were in the process of BCG treatment still, would you go ahead and finish those first and see if it worked the second time?
Yes, I would.
Okay.
I absolutely would.
Okay, great. Thank you.
I think we have time for one more question. Is there one more question out there? Okay, right in the center.
This is going back quite a few slides, but the list that you had of immunotherapy treatments, BCG, permigatinib, acertinin, and pretzel,
Yes.
are they all BCG type, like into the bladder, or any of them oral, or what's the differentiation in those?
So the pemigatinib is oral, but requires very specific mutations and is currently a trial, so isn't yet available. And then the pretzel that you mentioned, the gemcitabine pretzel, also is currently trial, and it's given in the bladder, not by mouth.
What's the medication in that one?
Gemcitabine.
Gemcitabine is the medication, okay.
And it's a TAR 200 pretzel, and they are also making a second pretzel for those with FGFR mutations, erdafitinib, and that's also going to be a trial as well, and it's given the same way in the bladder.
So just so I can understand it better, if I had to find a comparative thing, would it be like an IUD where it's sort of a thing that's inserted and stays there, delivering medication, and then it's taken out? And
that's perfect, actually. That's great.
Okay.
Yes. Now I can use that. Thank you.
And it really is about the exact same size as those little yogurt-covered pretzels that we ate at snack. except it goes in straight.
I miss those.
And once they put it in the catheter, it literally turns on
Curls
itself
up.
and turns into a little pretzel. And then when they go in to remove it, they just pull it out straight. It doesn't go out as a pretzel, so it's just as easy in and out. And they do replace it.
Yeah.
Is
then,
it
but it's-
attached to the catheter then, or is it sort of a
They
standalone
leave it-
embedded into
they
the bladder
leave it
somewhere?
in the catheter.
Yeah. So we put
They
a
push it in.
catheter in, we push it in through the catheter with like lubrication, and then it curls itself in the bladder. We take the catheter out and you go home. It stays in for 3 weeks. You come back the next time and we pull it out with the cystoscopy and we put a new one in.
Okay, so it's not removed with the catheter, it's just
No,
inserted with the
It's
catheter.
just inserted with a
So
catheter.
you don't go home with the catheter. But it's also one of those situations where you've got this little piece of plastic that's it's got little mutations and little holes that leach that medicine slowly over time. So are there any precautions that you think are going to come out from any of the chemotherapy that would be in there that people need to be aware of in avoiding while they're home for 3 weeks?
Yeah, we do tell people, like children, animals, etc., to stay away from those toilets. And we also, because it's this thing curled in your bladder, some people do have bladder spasms with it, similar to when they're holding the BCG. So they may have a little different side effects than they do with BCG. But you're feeling, for those of you who've had a stent, it's similar to the feeling potentially of having a stent inside your bladder.
So BCG, you hold it for 2 hours and then you void. This is going to stay in for 3 months.
3 weeks.
3 weeks.
And exchanged, yes.
Okay. And then exchange. So it's
Yeah.
kind of a permanent thing? It's
Is it
just.
like every
So-
3 weeks for 3
it's-
years?
So it's similar, good question. So it's similar to what she was saying, how it's just the duration of the trial. We don't know. It's been a year so far, but it could be longer. It's just what the trial limit is.
So another comparison, it's going to be like the Depo sub-Q where they put it in and then they take it out and put a new one in?
Yes.
Okay.
I just one really quick question, okay, that came up. I've seen a lot of CX Bladder on the,
Yeah.
well, why did Medicare stop covering the CX Bladder?
I do not know. I do not know the answer to that. I think that there are a lot of reasons that insurance companies do or don't cover things that are unfortunately out of everyone who's actually in the game's hands. And I don't know. I think they probably want better data to say yes or no for sure. I think that's probably the biggest thing.
It's also a cost thing for, the induction or the Inflation Reduction Act is causing people to cut back on some testing. And while it's less expensive for this test than, say, going to the doctor and having a cystoscopy, they're wanting to make sure that they kind of blanketed the whole category and said, no, we're not going to do this anymore. So I think this is something that Beacon is trying to keep up with and keep on top of, and working with the company that makes CX Bladder to help speak up about the benefit of it. Because during the pandemic they did something a little bit unique where they provided the CX Bladder in a home test kit, so you could provide a urine sample and send it to their labs, their CLIA certified labs, to do the testing. And you never had to go into the doctor, which, at the time when everybody, even urologists, were on COVID units taking care of those COVID patients, that was hard. They were understaffed. You didn't want to go to the hospitals, the last place you wanted to be, because you didn't want to get sick. So it was a wonderful opportunity for them, and hopefully the data that they're getting is going to be enough to get that back and get it covered again. Okay, one last question in the back, I think, because then we're going to thank our doctors because they have been phenomenal. But last question.
So I don't know if this is a consideration or not, but will bladder transplants ever be on the horizon?
There was just one, wasn't there?
Yes, and there was just one at USC. And the challenge with bladder, it's a good question, is that it's a very, I'm biased, it's a very unique organ in that it needs to both be able to expand safely to hold urine, otherwise your kidneys can get damaged, and it also needs to be able to squeeze to get urine out. And so it's hard to find a thing, equipment that can do that. Yeah, that can safely do that. And so they aren't. It's also hard to move it from one person to another and know that it will work, because it relies on innervation and nerves that may not be able to be safely sewn together.
But some brave soul is boldly going where no one has
Yeah.
gone before and trying it. And perhaps what they learn will fuel the next brave soul.
That's right.
So it could be in our lifetime or maybe not. But, at least somebody's
USC.
thinking about it.
Yeah, yeah.
Well, I want to thank you both, Amy and Katie. This has been phenomenal. And thank you again for stepping in. It's been just amazing. Thank you for bringing Vanderbilt to the house, and we appreciate